the way this is gonna go, I will instruct on a couple movements, then you will all break out, practice for about 5 minutes, come back, we'll do a couple more, and that's how the lab will progress, okay? So, super common if anyone has ever spent time in a hospital. Patients in bed, do they stay at their best position? They stay up in the bed? No, where do they go?
Bottom.
Slide to the bottom, gravity, right? Anytime you raise the head of bed, they're gonna slide down eventually. So we need to learn how to position them in bed. If we transfer a patient back to bed, we can't leave them with their feet hanging off the bed, the footboard, whatnot. We have to know how to move them up, okay? So first techniques are gonna be moving up and down in bed, okay? So first thing we're gonna do, let's go past, we've infection controlled and sanitized, we've introduced ourselves to the patient, we have consent. First thing we're gonna do is get barriers out of the way. Pillows, sheets, blankets, get them out of the way. So I'm gonna take your pillow. Okay, that way it doesn't hinder you when you're moving. The next thing is, I'm sorry?
Long hair.
Long hair, right. If hair is behind someone's back and they're laying on it and you go to slide them up, it's gonna hyperextend their neck, it's gonna pull their hair, won't feel nice, okay? So I think we're good here on the hair. Next, the bed height. Where should it be? Does it matter?
Hips.
Hips height, hip height, okay? So when we're in the bed moving a patient, bed mobility, the bed should be at the therapist height, okay? So it's based on me. Patients might get nervous. Oh, you're gonna sit me up, I'm 4 feet in the air. It's okay, like we'll lower you down before we get out of bed. I'm not gonna have you jump, but I need to protect my back, okay? That is probably one of the most common things that I see therapists in the clinic not do, because it's more time efficient. So do it with the bed low, that way they sit up and they can just walk or they can transfer right away. But it's not a way to prolong your career as an OT, okay? So get in the habit of protecting yourself, assuring the patient that you'll keep them safe. The bed has to be elevated to protect yourself, okay? So if you get hurt, they could potentially fall and get hurt as well. So we want the bed height about hip, greater trochanter area, more or less. It'll be based on where the patient is in bed. If you're reaching across the bed further, you may want it lower so you can reach the patient. If you are taller, you may want to have the bed higher. So it'll be based on the therapist. Okay? All I want to see when you're doing your competency is that you address the height of the bed based on yourself, and you don't just leave it down low because you've forgotten about it where you could injure yourself. Okay? So it's a general rule of thumb. If it's down at your knees, we're gonna have an issue with it. If it's at your shoulder, we're gonna have an issue with it. But anything here around the hip is appropriate, as long as it looks okay for body mechanics. So we have the patient up at my height, that way I can move him up in bed. We want to reduce shearing force, any kind of rubbing, friction, that's either not gonna feel good to the patient, or it's going to hinder what I wanna do. We're therapists, we wanna make sure anything we do in moving a patient is therapeutic. They have to get some kind of benefit from it. We are not just manual labor moving patients around for the nurses, okay? There has to be some kind of benefit. So I want the patient to help as much as we can. So I want you to bend this leg up, put your foot on the bed, good. Mr. Smith, wake up. All right, he's gonna put his feet down here. We're actually gonna bring them up a little bit closer. That way he can push, okay? Your patient can maintain this position, that's ideal. That way they can dig their heels into the bed, they can push. If they can't maintain this position, you could have a tech, you could have a nurse, somebody stabilize their feet, stabilize their knees so that they don't splay open. That way they have a stable surface to actually push against. Even if they're only able to help a little bit, it's still therapeutic at activating those muscles, and eventually they'll get stronger. Okay. Arms are already in a great position. I want them off the bed. If they're down on the bed, again, shearing, more friction. I want them up here across the shoulders, okay? The head, we don't want to hyperextend, we don't want to pull hair. So we will count the patient down. We'll say, okay, on the count of 3, I want you to lift your head and push with your legs. We're gonna slide up in the bed, okay? So that's his instruction. And then we will go hands-on with the patient. So where should my hands go? Does it matter?
Under the hips.
Under the hips. So we've got one idea for the hips. Anybody else?
Sometimes I just guard their feet.
Waist, feet, so they can push themselves up if they're able to. So we're always gonna go for a bony landmark, okay? If I just grab his torso where there's no solid surface for me to actually apply force through, it's gonna be uncomfortable for the patient, and his body is just going to move, or my hands are gonna slide, and he's not actually gonna go anywhere, okay? So I'm gonna go for the scapulas, okay? So I'm gonna go up superiorly on the patient's trunk. Down here, if we were to push up, we're kind of just compressing the spine, and it might just arch his back and not actually go anywhere. So I'm gonna go underneath the scapulas, both sides, and we're gonna push up in bed. Okay, what should my feet be? What should my hips be doing? Any ideas?
Bend at the knees slightly.
Yeah, bend at the
Quite
knees.
slightly.
Bend at the knees. My back should be, what's the term?
But, I mean,
What position?
inflatment.
So I've got AP stance, that's for our feet. Our back should be neutral, okay? Neutral spine. We don't want to be hinging over super far and applying a load where you're gonna twist and flex your spine, and that's a good way to get hurt. We want our feet, if you can see underneath the bed, AP stance, antero-posterior. So we've got 1 foot forward and 1 foot back. We have a stance foot back, and we have our leg forward. We're gonna transfer our weight. I'm not pushing him up with my arms. If you have a little old lady and you're big and strong and you just think you can do this, you probably can for a certain amount of time before you injure yourself. Okay, so always, even if the load, the size of the patient is smaller, still follow these techniques to protect yourself. Okay, so I have an AP stance. This is also an AP stance, right?
But
So I have 1
you're
foot
twisting
forward.
your trunk.
I'm twisting my trunk. My hips, are they facing the patient?
No.
They're facing away. So that is why the position of my feet does matter. I want my hips always open to my patient. That's across any technique that we do, so that we're not bending and twisting before we apply a load. So 1 foot forward, 1 foot back. Notice how my hip is over my back foot where I'm gonna be touching the patient. My forward foot is extended, or my leg, and I'm gonna weight shift forward onto my forward leg, okay? If I start here, I've got no room to actually weight shift forward because I'm going to be ending right where he's at. I'm gonna be trying to use a lot more of my arms. So my hands should be pretty much at my back leg with the patient, and then I should weight shift forward with him. Get your hands underneath the patient. We're not gonna jam our fingers underneath because they can catch their skin, it can rub, you can have really brittle skin, you can actually cut a patient with your nails, even if you're wearing gloves. So we're always gonna go soft hands, lead with the thenar eminence of your thumb, and fold underneath. Same thing on this side, underneath, and you're going to adduct your arms together. That way it's not just hands grabbing and sliding, you're gonna adduct your arms, that way there's more friction, you've got more control of the patient. All right, you ready?
Yeah.
So I'm here, I'm under the patient, I have my AP stance. On the count of 3, I want you to push with your legs and lift your head. 1, 2, 3. We move up. It's not gonna be a large distance. It may be a couple inches. You may reset, and you may go again, okay? Any questions? If you can stay there, we're actually gonna do the opposite a little bit. Okay?
Would there be any, I'm just thinking too, could you also then do, I guess on the same side, if they didn't need as much assistance, do like hip and scapula and just move that way?
So there are some techniques where it's just like underneath here. If you're gonna do like a unilateral assist like that, you're probably gonna have a second person. So that's another question I get. What if I'm not strong enough, or if my patient's too large where I can't manage their size with this technique? That's gonna happen. We're always gonna have patients that are bigger than you, patients that aren't able to help enough, and this, or precautions that prevent you from doing this technique. This is the baseline. We're gonna teach you base techniques, and then we will elaborate and go further on it as the semester goes on and in other courses, okay? What's an idea if we couldn't move the patient by ourselves?
Sheet.
Sheet, draw sheet, okay? So draw sheet underneath the patient where you would have a second person on the opposite side. You would be here, and then you would slide the patient up. If we don't cover it today in lab, it'll be covered in the subsequent lab draw sheet application. We also have something called a maxi slide. If anyone works in a hospital, it's 2 fabrics that are very slippery. That way they slide the patient along it. Makes it a lot easier to move and transfer a patient bed to bed. Okay. So that's moving up in bed. Our bony landmark is what?
Greater trunk.
Scapula. So moving up in bed, it's scapula. Moving down in bed, it's going to be something that was already talked about, hips. So again, if I stay at the scapula and I pull him down in bed, we're just compressing that spine, we're just gonna bend it. We wanna be down here, we want to be pulling the patient down in bed, okay? So your hips stay, your anterior leg stays how it was, but instead of my weight starting at his shoulders and moving forward. Now I'm gonna start on my anterior leg, and I'm gonna weight shift backwards to drag him down in bed. Let's bring those feet back up where we had them. Good. So before, moving up in bed, we started with his heels quite close to his backside, right? That way he can actually push. Here, we only have about 6 inches if we kept him like this to move his hip towards his feet, because the feet are static. He's gonna be digging those heels in trying to pull. So we don't have enough room. What I want is out here. We're opening up that knee angle. That way he's got like 1.5 feet now of potential movement down in bed. Okay, again, he's gonna lift his head on 3. Those arms are gonna stay across the chest. And I have my hands on his hips. So again, instead of jamming my fingers, it's gonna be here on his ischial tuberosity, or iliac crest. And we're here, we're gonna adduct our arms, so we're holding the patient. My weight should be on my forward foot, and I'm gonna weight shift back. I'm gonna push with my legs, okay? So on the count of 3, I want you to lift your head and pull with those legs as best you can. We're gonna slide down in bed. Ready? 1, 2, 3. Okay? And it moves a couple inches. And then if we needed to go again, I would reset my feet. My forward foot, the one that's pushing, should be in line with where my hands are on the patient. That way I'm here, and I weight shift back.
I have a question. Can
Yes.
the head of these go up?
I'm sorry?
Can the head of these go up?
Not this, hospital beds can.
So I want to give it the head of the bed and then it's, would that be easier?
So it's a good question. So on the practical, we're not, or the competency, we're not utilizing Trendelenburg for the tilt of the bed. Has anyone used that feature before? Know what that means? Yes. So these hospital beds will Trendelenburg. So the whole surface will tilt to bring the patient's head down, which would be helpful to move the patient up. Or they can go reverse Trendelenburg, lifting the whole surface up, be easier to slide them down. Okay? That is something you can use. That's another technique if the patient's too large for you to help, or just to make it easier on you. Okay? But here we're just gonna keep the beds flat for time's sake. And the goal is that we're not doing a lot of this bed mobility in the bed, because your transfer should be planned out so that when they lay down, they're already in the proper position. These are just in case we need to reposition. Okay? Questions on moving up or down? All right, let's go practice. I'll be walking around. There are 6 hospital beds. You'll be in groups of 3 or 4.
Alright, feed my patient first.